Okay, while I am sharing my screen with you all, I'm gonna go ahead and give you a warning that this lecture, it may be pretty intense for some people. So just be aware of that. I'm gonna share my screen, and then we will go ahead and get started. Once I copy of the lecture slides, yes. Let me go ahead and do that first. I'm gonna send you guys these slides, and then we can continue forward. Okay, just give me one second so I can send out the slides. Sorry about that. Okay, clearly I didn't turn my mic on before I started sharing my screen. So let me know when you all receive um, the email. Let me know if you guys received the slides. Um, so today we're going to have a guest lecture. His name is Professor Robert Fontaine Holman. He is African Diaspora Studies PhD candidate, and he will contribute greatly to this lecture for us. Let's see. He's an associate professor of African American literature and classic British literature at Emory University in Atlanta. And you will later see the way that he will be able to contribute to the lecture. So I'm going to give you guys a second to let me know if you've received the. Okay, so some people haven't gotten it. So give me one more second and let me get that resent out. Let's see. I may have to send these after class if it's going to take longer than this. But I should be able to get them sent out. So all right, here we go. I should have everybody in a group chat already, so I don't have to add you individually. Upload it directly to Zoom. Okay, just let me get this technical issue figured out, and then I will be able to try to do this. Let me see if I send it in an email. I guess somebody will have to upload it to Zoom because we're kind of running behind here.
Well, in the meantime, Dr. Jamelah, I'll just go ahead and say thank you for my introduction.
Yes, thank you. Thanks for being here.
Yeah, no problem. And I'm looking forward to interacting with you all as well. And I appreciate you all having me. Looking forward to this class. Are you all counting down the days to the break like I am? Definitely.
Okay, can you guys still hear me? Is there any feedback? I feel like there's some feedback. A tiny bit. Okay, let me try something else. Those slides should have been sent already. Let's see. So just let me know if you guys have received that. Let me know when my echo stops as well. Still haven't gotten it. Okay.
Your echoes stopped.
Okay. Thank you. Thank you. Thank you. Okay. The slides are on the way. It is attaching. Yes, troubleshooting definitely sucks because that took an extremely long time. Sorry to keep you guys waiting. But that's okay. We're gonna push through it. Okay, this thing is acting weird now. Okay, can you guys still hear me? I'm acting like I'm 100 years old and don't know how to use technology, but I really do in real life. So you have to forgive me. Okay, let's jump into it. So we are currently on the topic of, you guys can't see my screen, can you? Yeah, we can hear you, but can you see my screen as well? No, because it's not sharing. Okay. Okay. I don't know why tonight's so difficult, but we're gonna get through this. This is terrible. Worst TBR night ever, right? Okay, just as an introduction to Professor Holman, this group of students is in particular are studying for their medical entrance exams, which hopefully some of them take in the next few months. January. New test dates open in January through June. Class, I have informed Professor Holman on the topic for tonight. So he has some interesting contributions from personal experience with this as well. So he'll be able to answer questions when we come to that point. So just remember to send your questions to questions here, and we'll go from there. So all of the topics Professor Holman relates to our medical entrance exam prep. So all these topics relate to health and medicine as it relates to the medical entrance exam. So this is biosocial medicine. And if anybody can't hear me at any time, just yell at me or put in the chat. Hopefully everybody can still hear me. So our topics tonight will cover healthcare disparities as it relates to gender, class, and race inequalities in healthcare. We will look at some causes and examples of healthcare disparities. We will talk a little bit about equal access to medicine and advanced technology. So healthcare disparity is defined as the population-specific differences in the presence or absence of human disease, health outcomes, and access to quality healthcare across racial, socioeconomic, ethnic, gender, and sexual groups. And as you all know, these groups are evolving. So some of you may know that you can now choose your gender, you can choose your sexual preference. All these things are constantly evolving. And it looks like some people are leaving, but that's fine. They can come back in at any time. Who is affected most in the United States? So we have to remember that we're not just one secluded country. These problems are happening all over the world for all types of people. So your job as a physician is to kind of have a global mindset, especially if you're going into public health. So in the United States, we're going to focus right now on the United States since we're going to be practicing medicine in the United States for now. There's African Americans, Native Americans, Asian Americans, Hispanics, and another group that I did not put on here are immigrants, refugees, asylees, SIV, special visa immigrants. All these people are all affected by access to healthcare, and they experience healthcare disparities along the way, especially when transitioning into the United States. How are these groups affected? These groups are well documented in having higher rates of chronic illness. Okay, that's definitely not the right spelling for illness, but illness and disease, higher mortality, and poor health outcomes. So these people are more vulnerable, if you will, to there's healthcare disparities in Illinois too. I'll just do it like that and save myself with that spelling. There are health outcomes affect all cultures in some way. That is another thing I needed to say. And Jonathan, I kind of lost my train of thought when I was laughing at Jonathan's comment. Okay, continuing. Here we go. Oh no, you're fine. It makes the day go by fast and well. So here's a disease-specific example for healthcare disparities. So this picture you see on the left is a picture of it's a picture of the Bronx, in the ghetto of the Bronx in New York. And again, I warn you, some of these topics that we're going to be talking about today are, I'm going to warn you, they're pretty intense. So, we'll obviously keep it, positive, but just know that this is some real stuff happening across the United States and in healthcare as it relates to healthcare. So neighborhood concentrations and environmental effects due to those concentrations are thought to cause health disease in those neighborhoods. Environmental conditions of predominantly racial minority neighborhoods have a higher incidence of cancer, HIV, cardiovascular disease, opioid addiction, abuse, child abuse, sexual abuse, marital abuse, all types of abuse. The idea of concentrated neighborhoods is also linked to the housing crisis that you may have talked about in, say, an ecology class during undergrad or in a sociology class during undergrad. Okay. So conceptually consider Maslow's hierarchy of needs as we talk about these and go through these topics. Remember that Maslow believed that before any of us can focus on higher levels of satisfaction, which is one's basic needs, before any of us can, I'm doing too much at one time, guys. I'm trying to keep up with the chat. Maslow believed that before any of us can focus on higher levels of satisfaction, we must first have our basic needs met, and our basic needs are at the bottom of this triangle. So our biological and physiological needs have to be met before our personal growth and self-fulfillment can be met, and everything in between. Some of us do this better than others, meaning we can focus on two of these boxes at one time, but most of the time, if you don't have a safe place to live, you're not going to be focused on, being socially or morally responsible, because your brain is so stressed out from, needing to find a place to live, needing to find money, needing to find food, needing to find work. And it makes it even worse if you have a family. So it's compiled upon. Does that make sense? Yes, no, maybe yes. Okay, perfect. Okay. Okay, so here's a disease specific example. This is a photo of a C-section. And you'll see why in a second. Cardiovascular, HIV, AIDS, and infant mortality, as well as C-sections in minority groups, are higher than in European American counterparts, which are white racial groups, which correlate with a lack of preventative medicine among those minority groups. In addition to that, it is not just that, it's having education. So not having health related education also relates back to the causes of all these issues in those minority groups. If that does that make sense to everybody? And we'll get more into that in just a second. And as this, yes, okay, thank you. And as this relates to the medical exam, so you will see, they're not going to ask you specifically about these, numbers on here. They'll give you, it'll be in your your bio, social and psych section, and they will ask you, they'll give you your passage. It'll be within your passage based. So you might get an example of somebody suffering from cardiovascular illness, and they'll map it out in your graphs. Then they'll ask you questions on it. But having this knowledge going into the exam will put you ahead, because you will already have that background information on what's happening in the United States. In some of your CARS sections, you will get topics like this that relate to socioeconomic statuses. And obviously, you have to use critical analysis and reasoning to determine the correct answer within those sections. Okay, so here are some causes and examples in health disparities. All right. The leading causes of the lack of access to quality healthcare in minority groups. So I'm going to give you guys a minute to look over these, and then we will continue. All right, and just let me know when you guys are ready to move forward, and also let me know if you all have received the slides yet. Okay, are there measures that we should keep in mind for how physicians deal with interactions with patients from different background pertinent or is this just should apply, but it's really general knowledge that should apply. Okay, so to answer your question, this is definitely knowledge that should be applied in the healthcare field, which is why it's so important now at the beginning stages of your medical career, because they want to instill this in you before you get to the field. You'll see that these topics are things that people are still dealing with in the field. So in the hospitals during residency, you'll have doctors who don't want to work with certain patients because of whatever preference they have, because of whether they don't have enough money to pay, or whether they're Black, whether they're Asian. I had a doctor friend of mine tell me that she couldn't practice on a patient because they didn't want a Black doctor working on her, or that kind of thing. So as it relates to the MCAT, it's things that you should know going into medical school, and you will have classes on this. Obviously, it's just good practice to have ahead of time.
Dr. Jamelah, I have a question.
Yes.
Now I know it's within the patient's right to deny a doctor for whatever reason they prefer, but can a doctor be preferential on a patient?
Normally that only happens if it is a family member.
Okay.
Yes. Thank you for that question. That was a good question. Let me see if I can finish answering. Are there measures that we should keep in mind? I can try to upload the slides to Zoom. I've never done that before, but I will attempt it. I will definitely attempt it. Let's see. I'll do that now. Oh. Yeah, I don't know how to do that. Does anybody know how to do that? Upload it into the chat. You can just drag it into the chat. Okay.
And Jonathan, I see your question. And is it because quality of care changes due to familial ties? That's an interesting question. I know that, of course, Dr. Jamelah, this is her subject matter expertise, but I might chime in and correct me if I'm wrong. When operating on don't they kind of, I don't want to say frown upon, but try to fray away from doctors operating on family members just because of the pressure?
Yes.
That, basically.
Absolutely.
Okay. Yeah.
And and it's a liability issue. So if, they won't even let you sit in on a surgery if it's a family member. Yeah, exactly. Yep. Thank you. Yes. So, yep, that was exactly correct. Okay. I'm on iPad using my iPad to kind of do this meeting. So as far as dragging and dropping, I don't know how to do that on this thing. You mean drag it and drop it into the chat? I don't think this is gonna work, guys. Okay, I'm gonna try to resend it one more time in the email. I'm gonna send it, let me try to send it to one person. And then that one person, can you email the rest of the class so that we can see if we can continue? I can upload it. Yeah, that'd be perfect. So Jonathan, what is your, let me see if I have your email. Jonathan, yep, there we go. JC, there we go. Perfect. Thank you. Lifesaver. Um,
So since this particular topic's about different types of discrimination and how it pertains to the health field, have any of you all ever witnessed or been a victim of any of those types of discriminations that were listed in the earlier slide? Yeah, Jonathan, age discrimination is a pretty big one. It's not something people, really highlight, but it's definitely there. Yep. Brooke, were you a witness of that medical discrimination, or had it been inflicted on you? And I've also seen that too, Jonathan, where a lot of patients are like, "Oh, well, that doctor's too young," and things of that nature. I've definitely seen that happen as well.
and that's an interesting thing to talk about, the age, especially now because so many students are um, coming out of medical school at age 20 to 25. Like
Wow.
the age is getting lower and lower. And then in the same breath, they say that um, in the same breath, we get there's a doctor shortage. So there's so many factors to think about when we consider, the age and things like that, because we can't, once we fix one problem, we see another one rise up. Does that make sense?
Absolutely. Absolutely. And that kind of falls into the new doctors coming in, as well as the older doctors retiring that were born in the 50s and 60s, and even the 70s. It's interesting to see how that shifts.
Yep, absolutely. So, Jonathan, those slides should have been, um, okay. Can y'all still hear me? Maybe.
Yes, we can hear you.
Okay. Sorry, this internet keeps going in and out. And I apologize, everybody. I'm still trying to send these slides, but I just had to switch networks to see if it actually goes through this time to Jonathan so that he can send it to everybody else. Yeah, so that should have worked. So let's continue now that that's taken care of, and thanks for answering some of those questions. So are we ready to move on from this slide? And is there anybody else who would like to contribute to any of these things listed on the screen while we have it up, while we're talking about it? Okay, I'll take the silence as a no. It's okay. Nobody wants to participate. Just kidding. Ready to move on. All right. So here are some examples using a case study approach. So we're going to talk about, and before I get into this, let me just say, if you look at the world today, I'm going to give you something to imagine. Okay. If you look at the world today and you are at your workplace, or, school is a different story. So university versus workplace. Let's focus on workplace. If you're in a workplace and you have individuals who are in their 30s, 40s, 50s, 60s, and you notice the way they act, where do you think these behaviors come from? If they're acting kind of like, ego is a way being in their ego, or what's the saying? They are, how do you say it? What do you mean by that, Jonathan? So what I mean by the way people act, take longer to get to a certain, exactly. Some people take longer to get to a certain emotional intelligence, capacity for leadership, capacity for social social interaction, social conversations, or we just say, some people don't act their age, simply put. All those things, contribute, are attributed to having adverse, from this case study, adverse childhood experiences. So what I'm trying to say is, when you are in a workplace and you see people acting as if they're 15 years old and they're 45 or 50, or not even in a workplace. So you see people who are acting, just like Jonathan just said, a 45-year-old person, a 50-year-old person, should not be at home with their parents until they turn 60 or 70. Like that's not unless they have, some kind of special circumstance to where they can't live on their own or things like that. All this goes back to the effects of adverse childhood experiences. So the CDC developed a study about 10 years ago, which they are continuously following up on even now. The study focuses on adverse childhood experiences and how those experiences and incidences have lifelong effects on human health and well-being. So all the things that we spoke about earlier, regarding, let's go back up here, regarding the social economic status of individuals, or SES, the ethnicity, the gender, how they were raised, where they were raised. And it's not just one generation, it's several generations. if someone was sexually assaulted, that's going to carry over into their adult life and affect the way that they think, affect the way that they act, affect the way that they respond to different environmental influences, especially if it's in a stressful environment. The CDC approached the ACEs as potentially preventable. Not everything is preventable. So here is the pyramid of childhood adversity, which was adopted from a doctor at Johns Hopkins University, who also did a study on biosocial medicine, and he collaborated lots of research and case studies into a book. And this is what he came up with. So from infancy to old age, you have impaired neurological development. If childhood adversity continues occurring, you will go into childhood with cognitive and emotional impairment. Then you go into your adolescent years, which is teenage years, and you will adopt risky behaviors such as promiscuity, unprotected sex, abusive relationships, trying to find the balance between work and laziness. I guess that's the best way I can put it without, being mean about that. Adulthood comes excessive drinking, excessive smoking, correct? Mostly negative sanction-like behaviors. Health risk, yep. Health risk behaviors, which puts your personal self, you make a decision that would put your own body at risk because of a psychological matter that you didn't deal with throughout infant, childhood, or adolescent age. So this is not just on the people who experience this is on their parents. So their parents have a lot of influence over that as well. Your environment, where you were raised, what you hear, what you see, it all compiles into those risky behaviors if the cycle continues. And I I applaud those who actually take time to go to counseling, because we can't control, we can't always control as children how we are raised, what our parents' financial status is. We can't control that, but we're affected by it. Does that make sense? All right, so let's see. So moving up the ladder, I'm trying to make sure I check the chat as I go. Into adulthood, you start developing disease and disabilities, mentally, emotionally, psychologically, physically. I know you guys are aware that some biological, if you deal with, sometimes your cognitive well-being affects your physical well-being. So if you're always dealing with stress, you will get a headache and you will physically feel that stress. It'll translate into your body. And then continuing on, the more stress we feel throughout life, the more things we deal with or don't deal with, can lead to early mortality. I don't know if you guys heard that saying about living long, laugh long, laugh long, live long. But that relates back to that. So is there any questions on this?
I have a question.
Okay.
Can you hear me okay, Doc?
Yes.
Okay. So these all kind of stack on top of each other. So what kind of diseases or disabilities, I know it's kind of like a general question, but what diseases and disabilities have you seen an example of someone not dealing with their ACEs?
That is actually something we're going to get into just in a second.
Oh, okay.
Thank you. Okay, is there any other questions? We'll go into some examples in just a few minutes. Or just a few seconds, one of the two. So, biological perspective of ACEs. We have functional changes that are associated with the alterations in neurological structure. So functional changes are associated with alterations in neurological structure. This in particular affects the hippocampus, amygdala, and cortical areas. So what I'm saying here is when we don't deal with these problems on the screen now, as even from infants, there are functional changes in our neurological processes. There are structural changes in our brain and in our body when we do not deal with these issues. And that's another thing when you get into medical school that you're going to learn is that when you get into medical school and you guys are going over, different diseases and things like that, you're going to think that you have every type of disease there is possible on human earth and in space. So be aware of that. That's called the medical student disease, I believe. Okay, let's continue. So these public health problems called ACEs are also, can you guys still hear me? Yeah, exactly, Jonathan. So these are public health problems that are stressful and traumatic. These things are abuse, neglect, or any form of household dysfunction. All these are pathways to your social, emotional, and cognitive impairments when you reach adulthood. That makes sense. So these lead to an increased risk of unhealthy behaviors, as we discussed, violence, re-victimization, disease, disability, and premature death. So let's deal a little bit with re-victimization. So that is when you go through some traumatic event and then something triggers you, you're actually reliving that moment over and over again every time you get triggered by it. Does that make sense? Would that be?
I'm sorry. So you said
Yeah.
when a person doesn't deal with a stressful or traumatic situation and they get triggered, they're actually reliving it.
Exactly. When they're triggered, they relive it over and over and over again. So yes, Jonathan, that's a form of PTSD, but not exactly. So this re-victimization is, let me see if I can give you a good example of this. So say someone is complaining about the tone in somebody's voice. That tone in somebody's voice could be related back to the way that a mother or a father spoke to that person as a child, and that person is now feels re-victimized. Does that make sense? So that means they're living it in that moment over and over and over again. Does that make sense? And another form of that word means can y'all still hear me?
Yes.
Okay, thank you. Sorry about that. Another form of that word is when you're in the health field. So there's different variations of this word. So if there is in context here. So, okay, let's not worry about that part. I think I was gonna throw you guys off of the focus of the ACEs. So we're not gonna go into that right now because we have a little bit more to cover. But we will talk about that. That example was a little bit, the example that I thought of in my head was a little bit out of context, so that's why I did not share it. So we're gonna stay on topic. So here are a few types of those issues: the abuse, neglect, or household dysfunction. And we can talk about these as well. I'll give you guys a minute to read over these. And just let me know when you guys are ready to move on. I'm going to read Jonathan's chat really quick. Okay, let's see what Jonathan has to say. The clause 5 years older than you seems a bit ambitious. Is there a reason for this distinct age gap under sexual abuse? A stranger who was at least 5 years older than you. You're right, it is extremely ambiguous. No, there's no specific reason for that specifically. The only thing I would say about that is the fact that people older than you should know better than you. So, if it's a I don't know. This is, like I said, this is going to be this lecture is going to be hot topics. So if you were, for example, ever sexually abused or molested by anybody who was older than you, in your mind, you think, oh, they should know better. They shouldn't be doing this. But as a child, you're like, I'm not going to say anything because I don't know what's going to happen if I say anything, especially if it's a family member. And sometimes you have those households where you have a kid who does speak up, and it's maybe a mom, a boyfriend of a mom who doesn't believe the kid because she's so desperate to be in a relationship with this man. So she doesn't want to, kick the man out or press charges if the kid says anything. So the kid may have seen that already and then it happens again, and it's a continuous issue that has not been correctly addressed by the parent. So it's the fact that the fear. Thank you. Thank you for that specification, Jonathan. That was a good example to explain. Yeah, perspective of the child, right? All right. Any other questions on that or comments? Okay, so here are our household issues. I'll let you guys look over this really quick and then let me know if you have any pertinent questions. I don't want to just read the slides off to you, so you guys can go for it. If you have any questions, just go ahead and put them in the chat, and then I'll look at them shortly. No questions here. Okay, sounds good. So these are all things that cause those long-term effects in healthcare disparities. These are all things that contribute to the way we are, or the way that we have developed or not developed, because some people may not have experienced any of this stuff as adults. Nope, not at all. So that's just something I left out. So thank you for pointing that out, Michaela, sorry. Violence can occur against men and women. So violence against women. These are just examples. So it can happen for both genders, for all sexes, to any individual, period. So yep, no, thank you for pointing that out. I'll definitely have to change that for my next lecture. To be more specific or less specific. Okay, so I'll let you guys look at this one and then we'll move on. I'm not sure what you mean by that. Can you explain that?
It just seems like if someone in your family is there to help you, make you feel special, isn't that the opposite of emotional neglect?
Someone in your family helped you feel important or special. You felt loved. People in your family looked out for each other and felt close to each other. Your family was a source of strength and support. So emotional neglect, they're saying in this slide, emotional neglect would be the opposite of what's being. Yes. So yes to your question. It's the opposite of this. So if you did not get this, then that would be emotional neglect. Yep. You're welcome. And physical neglect, there was someone to take care of you, protect you, and take care of you, take you to the doctor when you needed it. If you didn't have enough to eat, your parents were too drunk or too high to take care of you, and you had to wear dirty clothes. Yeah, that's physical neglect. Thank you. Great question. Yeah. So we will go into this. So on the following diagram, we're going to look at some effects of being exposed to stress or trauma in early adversity and how it has a lifelong impact on any individual. So Robert, if you want to go ahead and jump in, feel free. We're gonna give a few examples on this and kind of tag team different things.
Well, sure. Once again, it's nice to be here and glad to present for you all. So I'll just give you a little bit of background about myself. I'm from a little small town in Missouri that is it's predominantly white. It's a small town, farm town and stuff. And I don't know if you all are familiar with small towns, but they're really hyper fixated on sports. So just kind of listening to the lecture, I can tell you all I've been medically discriminated against as a teenager, especially before I knew how to defend myself. I know one student in here earlier had talked about a knee injury and how if she had kept on pushing, like she was first told to, that she wouldn't be able to walk now. I can empathize with that. I played football and I ran track, where I was way better at track than I was football. And I sustained, knee injuries. But I got told the same thing, you're too young to have bad knees, or, just stretch it out, walk it off. To the point I thought, there was something wrong with my mind as far as like what I was feeling and things like that. But I mean, it even got to the point where when we were getting ready to run state, and I mean, I had a really bad knee, cortisone shot without my mother's permission. I think I was like 15 or 16. But my coach took me to get a cortisone shot in my knee about 5 or 6 days before our state track meet. So I don't know if you all are familiar with cortisone shots, but it's for particularly my situation where the cartilage in my knees had deteriorated, and it provides that cushion. So I felt like I had new knees after a few days, but I was swollen for a while. But things like that, even the fact that my medical concerns went so long being ignored, to the point I began to question myself. And so I totally understand the different types of discrimination. I don't know if they thought it's kind of like I guess it would be considered an age discrimination. Being told you're too young to feel a certain type of pain kind of falls into that, and I really was feeling that pain, but also something Dr. Jamelah that she said that had triggered my thought, kind of switching the subject over to traumas and traumas having not been dealt with. I used to have a roommate a couple of years ago, and I mean, we've been cool for 5 or 6 years, and they had some stuff going on. Just it seemed like it was just things coming from every end: legal trouble, financial trouble. There was some parental discrepancies as far as him being able to help raise his child. Had all these things going on at once, and one night it just hit him. He said he had a recessed thought about being molested when he was a child, and he was trying to figure out if it had really happened or not. And then things just kept going downhill, and he literally snapped out. He was not the same person that I've known for all those years. I mean, just to look in his eyes, the way he was acting, tearing stuff off the walls, it's totally uncharacteristic. And so what I actually just learned from you is that I didn't know when people experience traumas like that they relive them, which makes total sense. But also how it was handled. When I called the emergency number and told them that my roommate was having some issues, I believe it was a mental issue, and that they, need to bring an ambulance or something. They actually didn't bring an ambulance. They just brought 4 or 5 police, which didn't help. It truly escalated the situation. Because of course, they asked his demographic, how old is he? His race, his preference, all those things they asked. And I'm thinking that the ambulance is going to pull up maybe 1 or 2 police. And there's actually about 4 or 5 police cars and no ambulance, no mental health professional of any sort. So it's interesting to see that is still prevalent. And he had to actually convince them once he was admitted, he had to basically convince them what he was dealing with. They just thought that he was just having some type of episode, and he had to actually talk to them and convince them that he just wasn't crazy. He just was literally dealing with something. I see a question. You think that mental health in certain demographics were frowned upon and that's completely overlooked? Oh, yes. If you allow me to answer that, I will.
Yes, go ahead. I'll tag
okay.
you.
All right. So that's an interesting question. Thank you, Jonathan. Do you think that mental health in certain demographics were frowned upon and thus overlooked completely? Absolutely. I do think that mental health in general, seeking mental health was frowned upon, specifically in the Black community. When mental health became popular with psychology and sociology, it was looked at as more of a soft science. And it was only socially, it was looked at as it's only for crazy people. Then things began to change when they found out how effective it was. And then it was only reserved for those who could afford it. Some of that stigma still stuck with the African-American communities about not readily wanting to seek any type of mental health for the simple fact that it has never been available to us in such a way that you can openly talk about it or receive that type of help. And not only has it not been available financially, but socially, it wasn't acceptable. And I think we all know that, social pressures play a big part in decisions we make for ourselves.
Mm-hmm. And to piggyback off of that, yes, Jonathan, absolutely, when you're young. Well, we'll come back to that part. But piggybacking off of what Professor Holman just said, I worked in refugee and immigration on a federal contract. And I dealt with the medical issues amongst the refugees. And we had an immigrant come here. I don't know if you all know about, okay, we're just going to go over it. So in the African countries, there are different countries in Africa. Among the different countries in Africa, um, there are different groups, different what's the word, Professor Holman? The different sects, SECTS of African
Yes.
tribes. Yes, thank you, Mo. There are different tribes. Yep, sex for religion, and there are different tribes. So there was a husband and a wife who got married from different tribes who came over into the United States. When they got here, they met me. The female was from a different tribe as the husband. After they got here, they had 90 days to resettle through my office. So that means they had to be dotting their I's, crossing their T's, making sure that they are, our government does a really good job of overlooking the process, making sure everything is good to go. People are doing what they're supposed to do. So my job was to make sure that everybody had everything together. Coming up to that 90-day mark, we had an incident where the African woman, the female, was being abused physically by the male. Okay, the male of the family, because of the tribe issue. He told her that when we get to the United States, I'm going to kill you. And he tried. He tried it. He stabbed her in her femoral artery and tried to kill her with a knife. He went to jail and ICE had to come get him. So getting abused by her husband is my main point here. She was too afraid to seek help. But the factor of being an immigrant comes into that plays a big role into that, because in the African and African American communities, getting help for abuse is looked down upon. Getting help for mentally processing what had happened to her, she just, she kept saying, no, that's not what we do, things like that. And even her family was encouraging her to not do it. So, and they had 6 kids together when they were here. So that's just a little background on that. And as it relates back to early adversity and the lasting impacts, those are cultural things mixed in with, the reason why they even came to the United States was to seek refuge, a better place to live, better food, having, not even better food, but just having food in general, because their country is going through some kind of civil war in Africa. So they came to the United States on an immigration refugee status. So all these things, obviously, I'm sure you guys know how to relate it back to medicine now. But let's look in the comments and see. When I lived in Africa, it was more an expected part of life. Yeah, what do you mean by that, Brooke? Abuse against women and children. Is normal. It's normal in other countries. Um, sad. It's sad to say that, but it's true.
And I find it's an interesting caveat that immigrants come to the United States to, to have a better life and have these securities that that aren't offered to them in their home countries, but they're still dealing with things like domestic violence of sorts and emotional abuses that are expected cultural norms in their home countries.
Yeah.
I just find that's interesting. I never looked at it like that, and I didn't know that was present.
And even the fact that during during that time, I had to actually teach them the laws. I had to teach them that having female circumcision is illegal in the United States. because some people would secretly do it. I would have to tell them that, abusing a child and neglecting a child is illegal in the United States. Having sex with somebody under the age of 18 is illegal in the United States. All those things that we kind of take for granted or know, but don't really teach, those are some of the things that had to come, even in the African communities, those things are kind of not talked about at all. But that's the African community. There's a difference between the African community and the African American community. So just think about those things. And then it's not just those communities, just like Mo said in the Middle East, it's occurring in the Middle East. At the beginning of the lecture, I told you guys these issues are happening all over the world. It's not just in one place, because everybody is a human and we all deal with human issues, if that makes sense. That's why we have global health crisis and epidemics and pandemics, because we're all human. We all are built of the same things, of the same material. And your role as future physicians and doctors is to help mitigate those issues, not add to those issues. So our role as doctors are to mitigate and provide better examples for those who come up after us and those who also want to contribute to the medical community as a whole. And then if Professor Holman, did you want to continue, or should we move forward? Did you have more to add to that?
I'm sitting over here talking and my microphone's on mute.
Oh.
Imagine that. I'm just looking in the chat, somebody said, this is common.
Yep. Legal systems in other countries protect abusers. Wow.
Yes, that's very true, Mo. And it's interesting too, if you take that and supplant it into the medical field. Just from my knowledge, a lot of women aren't allowed to make medical decisions for themselves. Either their fathers or their husband have to make those decisions, even if it's against their will. So something that I always found interesting was that a lot of physicians in these different countries play a part in the subjugation of women and unfair healthcare and practices within the medical field. It's just something interesting, something interesting to look at, because like another one of your students said, sometimes we don't realize how good we have it over here, and we do have it better over here than a lot of other countries as far as our consideration for our healthcare and being able to make these decisions and having it available to you. Of course, it's still a crisis over here as well, but I definitely say on a smaller scale, some of the things that we do deal with are considered a small price to pay for some of the freedoms that we are able to exercise and enjoy over here in the United States.
Right. And on the flip end of that, for example, in France, they may not have the best technology or the best this or the best that, but they do have a good source of everyone having health care access. So access to health care. So if you live in France, I'm not sure how the rest of Europe does it, but if you live in France and work in France for 1 year, you have free health care, no matter if it's a cardiothoracic surgery or whether it's going to the doctor for preventative medicine. And every pharmacy has a licensed pharmacist who operate as doctors. So like, we have Walgreens here. In France, you can't go into a pharmacy and just pick something off the shelf. And you have to have a prescription. They do have things like that, but certain things like vitamins and cortisone and things like that, you have to have a prescription for some reason. But I don't know if you guys have experienced that or going overseas or not, but that's something to note.
And just lastly, well, maybe not lastly, but my last comment on this particular subject is I read an article recently about the high cesarean section rates amongst Black women and how it's linked to infant death or fetal death and complications with women dying during childbirth. So there's a place in New York. It's right outside of the Bronx, I guess. I can't quite remember where it was at. And to a quick tangent, that picture that you showed at the beginning of class, looking at that initially, you wouldn't think that was the United States. You wouldn't think that was America. Looking at that, but so going back to the story, the article that I read, it was a husband and wife. They were both African American, and she had went into labor. The neighborhood that they lived in the hospital in relation to it, had a 90% cesarean section rate amongst Black women. So even though her water broke and she was in labor, they drove 45 minutes out to the suburbs, where it was a predominantly wealthier neighborhood and a higher success rate of birth and successful births amongst the mothers there. So just even having to take that into consideration, it's scary that you would have had to drive an extra 45 minutes to ensure that you're going to live through a normal full-term pregnancy because of the medical disparities or whatever stereotype that the doctors are operating in within their bias. It was just eye-opening. So
I'll give you guys two other examples to piggyback off of that, because the medical experience is one part of it. In rural and urban areas, there's a lack of physicians, a lack of surgeons, providers, primary care doctors. That's why there's so many scholarships out right now for people going into medicine in those fields, specifically in those areas. So the lack of medical experience of the doctors is one idea. The mortality rates probably were increased at that location that the couple traveled from. And then on top of, there are more C-sections in certain minority communities happening than there are natural births in the European American households. So that is something to keep in mind and to think about. A lot of these topics correlate with other greater, things that we deal with as a community as a whole, which is basically all racial, ethnical, and sexual groups. There's so many things that compile onto one another. It's hard to really pinpoint where and why it's happening. So researchers do their best to correlate, but remember that you can't always mistake correlation for causation. So that's something to be careful about in your critical analysis and reasoning sections, as well as your decision making on the exam. So don't overthink the exam. Take it, use what you have, use what you know, and use what they give you on the exam. And then that, I think I'll just leave it at those two things. Unless you guys want to hear another interesting story about surgery, about transplants.
I'm game.
Okay. So yeah, so there's one other kind of stereotype thing going on. So you guys know how on your licenses you can choose to be a donor or not. On some people are choosing, and this has been happening over the past few years. It's some kind of mystery going on with surgeons who perform transplant surgery. So some people are choosing not to have that on there, to not be a donor due to the fact that um, during a transplant surgery, during a surgery in general, if you're a donor, there was research done that doctors will choose to stop surgery because you have you have a certain window to save the organs. So if they kind of see you're not making it, they're going to call it. They're going to transplant due to the fact that you're a donor. There's other people in the hospital waiting on, there's donor lists, things like that. So that's more research you guys should definitely research. If you're going in as surgeons, I would suggest encouraging people to be donors, but don't quit the surgery before you save the person's life. If you can save the person's life, do everything you can to save your patient's life, so you don't disrespect the Hippocratic oath. Okay, and the Hippocratic oath is something that you will take as an honorary candidate of medicine. Okay, let's move forward. Any questions? I feel like some people forget about the oath. Yeah, that's true. Once you get in the field, you start to feel yourself a little bit, and then you forget everything you worked hard for. So don't do that. Yeah, thank you, Jonathan. I'm glad you're enjoying it. Okay, we're going to listen to this really quickly. We just have about 20 minutes left. That is a topic that could end up in MMI. I feel like that's a topic that could end up in an MMI. Physicians are people too. They can be terrible. That is true. Yep. And this is the thing. So I'm not sure what kind of backgrounds you guys come from. And if you feel like sharing, feel free to share. But okay, how do we go from this? Okay. It's going off of what Mo just said. And Michaela, you're going to have to tell me what the MMI is for. So it's going off of what Mo just said. Physicians are people too. They can be terrible as well. If you come from a higher socioeconomic status and you've always had the best of things and you've never struggled in your life, and it's not a bad thing, like that's good. The bad part comes in when you become arrogant, you become like you're better than everybody else, when you start doing what those people did a few months ago by paying for their kids to get accepted into college. When you become that way, it kind of sets you apart from the people who put the work in. They study, they might have money, they might not, they work hard. It's a difference. I don't know if you guys have met those people or you are those people, but there's a difference in the quality of healthcare and the passion and the compassion that comes from a doctor who has put in the work. Because I've seen doctors who don't put in the work. They treat their patients like crap. They treat their nurses like crap, and it just makes for a bad work environment, a bad patient experience. And these are all things that we all can contribute and learn from as a whole, to make healthcare better in the future. So again, as future physicians, be the one to mitigate, not add to the problems that we already have in healthcare. That's the takeaway. Really had clear vision. Let's see, physicians are people to ask. Turned director of Syria. Oh yeah, he's motivated. Okay, so let's just watch this. Let me know if you guys can still hear. The video is only about 4 minutes long, but if you can't hear, just tell me and I'll try to fix it.
This is my neighborhood. I grew up in this building. This is a great community now, but it's had its share of problems. When I was a kid, our community had high unemployment, a lack of resources for families, and lots of kids hanging out with no adult supervision. You might have heard about adverse childhood experiences, or ACEs. ACEs are traumatic events in childhood, like abuse and neglect, that can increase risk for future problems. But they don't have to. The good news is that ACEs and their consequences can be prevented. Take me, for example. I was at risk for ACEs, and despite all the things that put me at risk, some pretty incredible people helped make sure that I wouldn't become another statistic. Come on, I'll show you around. That's Jackson. He's a cool kid. His dad left when he was 2, and his mom works 2 jobs. I hang out with him every Thursday night and help him with his homework. Sometimes we grab ice cream. It's fun. Plus, he has another adult role model to learn from and trust. That's Mr. Martino. When I was a kid, he let me help him at the store sometimes after school when my parents were working late. He did that for a bunch of us. My dad actually found his job as a mechanic because of Mr. Martino. This helped our family in so many ways. Not only did my dad have a steady paycheck, which eased his stress about paying rent and buying necessities like food and clothes, but he was also a lot nicer to me, my brother, and my mom once he started working a job that made him feel good about himself. When communities come together, they can do so much to prevent ACEs. Mr. Martino and other local business owners put together a series of career workshops to help people like my dad find work. My mom also got a job with a company that allowed her to work from home and spend more time with me and my brother. Mariana has just gotten out of a class about handling challenges of single parenting. The clinic offers free childcare so Mariana's daughter, Ella, can play while Mariana's in class. The class helps parents like Mariana develop positive parenting skills, not just for babies and toddlers, but for teenagers too. This is another way our community has come together to give families the resources they need, and just one more way to prevent ACEs. This was my school, Riverside Middle, right in the heart of town. These kids are here for a sponsored summer camp. This community-supported program helps families with affordable, quality childcare and helps kids get tutoring and learn life skills. When I was a kid, I spent a lot of time at this school all year long. There was one counselor, Miss Greer, who I remember more than anyone. She was a really good listener. Miss Greer helped me and my brother get involved in after-school activities like baseball and soccer. Our coaches were super nice and were mentors to us. Staying after school for practice kept us and a lot of other kids out of trouble. When schools help take responsibility for preventing ACEs, everybody wins. My life could have gone in a completely different direction. Studies show that ACEs can have long-term negative effects on kids' health and well-being that may last into adulthood and even continue in future generations. But by people and groups taking action, ACEs can be prevented. In fact, there are 5 known strategies that help stop ACEs before they even start. You can implement them in your own community, just like we did. How? By strengthening economic support for families, by changing social norms to support parents in positive parenting, by providing quality care and education early in life, by enhancing parenting skills to promote healthy child development, and by intervening to lessen harms and prevent future risk. So, now you know my story, and you've seen the prevention strategies in my community that helped me beat the odds. I had healthy relationships with my family and friends. I learned how to take care of myself and make good choices. And today, I'm a mentor to other kids who need some extra help so they don't become an ACEs statistic. Safe, stable, and nurturing relationships and environments are essential to prevent child abuse and neglect and to assure that all kids reach their full potential. Are you thinking what I'm thinking? Banana split? You got it.
All right, so do you have any questions from that? No questions, same here. Okay, so we're gonna look at just a few more things. So here is a case study. Remember earlier when I told you all that your functional changes are associated with alterations in your neurological structure when you deal with abuse, neglect, or household issues. That relates back to this chart. So here's a specific case study. So in this study from the American Academy of Pediatrics, this is a PET scan, which measures the biochemical and metabolic function of your tissues and organs. Obviously, I hope you guys know what a PET scan is by now, positron emissions tomography. So this PET scan of the brain is of a Romanian orphan who was institutionalized shortly after birth. You guys may have heard of this case before. But it shows the effect, and this is on the right. So I'm looking on the right. Shows the effect of extreme deprivation in infancy. The temporal lobes, which are right here, right here. Sorry, I was being silly for a second. So these are the temporal lobes. They regulate emotion and receive input from the senses. So this is the difference that you will see. And this child suffered from emotional and cognitive processes. So the red that you see on the screen are the most active parts of the brain. So this is the front of the brain from the PET scan, and this is the back of the brain. So if we just look at one side to the right, we'll see that the temporal lobes of this abused child are very much less active or not active at all. The black that you see is inactivity. So more than likely, this kid was asked to perform a movement or a thought process. And the PET, when you respond, your brain relays the message. So your sensory system relays the message to your brain, you respond, it lights up the PET scan. And this shows you that there are inactive parts of this child's brain due to the trauma that the child incurred as an infant. On the right side, you'll see that this is a normal functioning individual, a normal functioning brain of the same, a child of the same age. At birth, only primary structures such as the brainstem, which is here. If you compare these images, there's less black region here than there is here. So you know and understand, now that you know that this child who is abused has a less than normal, which is on the left, activity near the brainstem.
I have a question, Professor Jamelah.
Yes. Can you hear me? I don't think I can hear you. Professor Holman, I think maybe you're on mute, possibly. Michael says Michael wonders morbid. Wow. Okay. You guys are. Okay, we're gonna continue because I can't hear Professor Holman. When you get reconnected, maybe. Can you hear me now? Okay, I'm gonna continue and let you get set up on your mic. Okay, so on the left, we have the PET scan of a normal brain. The regions in red are the most active forms, the most active regions when, for example, the same question or functional process is asked of this child to perform. So early childhood experiences wire the circuits. So that's something that you probably have already went over in psychology class. As you develop as a child, those childhood experiences help wire the circuits, meaning when you get when you get a command or whatever from your parents, the more a child understands and listens and is not hindered in learning those different commands or activities, the brain is developing. So that's why it's so important to that's why it's so important to be careful how you speak to children, how you raise children, and how you interact with children, because this is what happens. Okay, so yes, what was your question, Mr. Professor Holman?
Okay, yeah, I'm sorry, I lost my connection for a moment. So I'm looking at this brain on the right, an abused brain. So with that pyramid that we looked at earlier, not Maslow's hierarchy of needs, but the other one, like the trauma, there we go, the pyramid of childhood adversity. Is that like what starts, like I know it's the base, but is that like literally the brain not developing and malfunctioning, is that a direct contributor to that bad health? Like
Absolutely, yes.
Okay.
Yeah, so this is what I was emphasizing earlier, and the PET scan of the brain kind of ties it all in. So from infancy, this is what I meant by impaired neurological development. All these experiences throughout a childhood and throughout adulthood or adolescence contributes to this happening, this
Okay.
poor development.
So,
And
I'm sorry. So even if you were to cut out the health risk behaviors, such as those kind of go-to behaviors or those comforting behaviors that actually end up causing more harm, such as we talked about earlier, abusive relationships, smoking and drinking, even if you were to take that factor out, does this impeded brain development still directly affect that long-term physical health?
yes, absolutely.
Okay.
Because if our brain, that goes back to me, and great question and great points. As we think about back to when I said, do you see how adults are acting on your daily life, in your daily work, on your job, things like that. So the way that people are acting as adults, that relates back to these sections of the brain not fully developing at some point in their childhood. But this is an extreme version. So everybody's brain doesn't look like this. So the one on the right is an extreme version of an abused brain. Okay. So just keep that in mind, everybody. So, but thank you. That was a great question.
Yeah, no problem. I'm seeing how this ties in together with being with someone growing, how you said, like someone growing up with a lot of money and that nuclear family structure versus someone growing up in a really impoverished and having food insecurity and housing insecurity can contribute to that that abuse and things of that nature. That's really interesting how that all ties in.
Yeah. Yeah. Thank you. And that also leads to the early mortality. For example, this kid in this PET scan probably would have early dementia or, things like that, because your brain makes connections with everything. When your brain isn't connecting to the environment and things like that, you start to forget. When you're not connecting to new forms of learning, that leads to dementia and Alzheimer's. Those are different contributions, and dementia and Alzheimer's leads to early mortality at a young old age. The old age is becoming shorter and shorter. I'm not sure if you guys have noticed that, but a lot of young old people are dying when they're young. They're older than most of us, but they're still dying pretty young, if that makes sense. So here is the last slide that we're going to go over today, and then we're going to follow up with a few questions, and then we're going to have to close out. So I have, let me see here, the impact of childhood trauma. So those who suffer from childhood trauma, you might have emotional issues in your relationships, issues with mental health, which include depression, anxiety, negative self-image, low self-esteem, PTSD. You might have episodes of suicide or suicidal thoughts. One of my little sister's best friends committed suicide when she was only 12 years old because she felt that her parents did not love her. And she killed herself when she was in middle school. So that was pretty tough. There's, you'll notice in your relationships, you have attachment problems, afraid for people to leave. Yeah, so I'll let you guys look at this while I answer Mo's question. We hear about these individuals with the ACEs, but we also hear about incredible comeback stories. What might these individuals be doing that is different from others that allow them to turn their lives around? So I'm gonna be the epitome for this question. So thank you, Mo, for bringing that up. We focused so much on the negative that we didn't look at the positive things. So some people do come out of these traumas and live incredible lives. That's really, really, really important to note. And they live out these incredible lives with passion and compassion and with, no strings attached. Every now and then they have flare-ups of, maybe emotional flare-ups, but overall, they live incredible lives. So I'll tell you guys a little bit about me. So we can close out class on this note. So my story, briefly in 30 seconds. My dad died when I was 10 years old. My mom was on drugs heavily. And she abandoned us, me and my siblings. So we grew up basically in that no food, no lights, no electricity, no water, that kind of background. And then we were moved from place to place to place. Some of us were adopted out of the family, which means somebody adopts you and takes care of you. Um, and then, some of us went on to get college degrees. Um, I went on to work with people of the same backgrounds as me, meaning refugee and immigration, healthcare, things like that. So I, I and these people, some of us didn't have we didn't have the resources, um, we didn't have the financial resources. We were educated, but we had to work for it, like work at it. Meaning I went to public school, I went to private school. At some point in my life, I went to both. I changed high schools twice. I never got in trouble in school, but I also, what was I gonna say? I received like approximately $100,000 in academic scholarships because I never got anything below an A from kindergarten to senior year of high school. I took AP classes when I was in high school, and this is coming from somebody who had no parental, nothing. Like nobody tutored me, nobody did anything. It was straight just working hard in school, understanding, staying after school if I needed to get more understanding from classes, things like that. And I graduated in the top 10% of my high school and college, in undergrad. And yeah, and then I went on to do my master's at one of the most prestigious schools in the United States. It's called the Harvard of the Midwest. That's WashU in St. Louis. And then I received military honors from the Marine Corps as an officer in public affairs. And let's see. So that's kind of my background. And then there's doctoral studies and medical studies that I am currently a part of. So it's a lot. Like it's intense, but some people have what it takes to come out of those traumatic experiences. It just takes grit. I think it just takes grit. And along the way, my grandparents died. They died of cancer, so there wasn't anybody to lean on. Um, I didn't have my parents to have my back or support in anything. So it was learning on my own, learning on my feet. And then there's what other factor was there? Not having the network of support. So like someone from a higher socioeconomic status, they may be in good financial status and good networking. So their parents might know people who might help them get into different programs in medical school or anything like that. So it just takes grit, I think, and passion for what you're doing. And another thing I want to add is along the way, having grandparents die of different things. I also had my little brother die of a heart problem. So he had cardiomyopathy and Marfan syndrome, and he was 1 week away from his heart transplant, and he couldn't get it. It was the day before the surgery was scheduled. The head of cardio came in, pediatric cardiothoracic surgery came in and said, he's not strong enough to make it. So he was on ECMO for a week, and then they had to let him go because he would not physically make it through the transplant. So it wouldn't make sense to lose a heart when another kid could, use that heart and live a longer life. So it's different challenges that are tough like that kind of give you that passion and that drive to not give up. along the way. But that's that. Yeah. Wow. Thanks,
I
Michaela.
think it is.
Go ahead and embarrass me,
I
Michaela.
think it is said that you have an amazing amount of grit, and I think just in general, people who have ACEs, I can say, yeah, definitely one benefit from that is that once your mind is on something, you're going to complete it, and nothing's going to get in your way. Anything used against you is going to become your tool for your success. That's definitely a positive light, and I thank you for letting us hear your story too.
Yeah, no
Professor.
worries. Thank you. And thank you, Professor Holman, for being on here with us. I'm sure that the class enjoyed all of the input that you brought to the table. So I appreciate that. And thank you all for a great session with TBR. Hopefully they have things together next semester for other students to come back and hear these lectures. Mindset and allies. Yep. All right. Any other last questions before we end this session?